Hello, thank you very much for having me here at the PSYCH Investor Summit. My name is Dr. Ben Sessa. I am a consultant psychiatrist and the Chief Medical Officer at Awakn Life Sciences, a new psychedelic startup that has just recently gone public, and we are now trading on the NEO Stock Exchange. Great pleasure to be here today. I'm going to be talking about addictions and the use of psychedelics in addictions, but primarily focusing on MDMA. As it is our team here at Awakn who've carried out the world's first addiction study using MDMA for alcoholism, and we intend to go forward with far more research and clinical activities in that field. So I'm going to take you through that history. So in order to understand how MDMA works, you really need to understand the concept of trauma and attachment. And when it comes to childhood trauma, as a child and adolescent psychiatrist myself, I worked for many, many years with maltreated and abused children. And we often think about sexual and physical abuse as being the big forms of trauma. But I always say, don't take your eye off the ball when it comes to emotional abuse and neglect. These aspects of abuse can have a very significant effect on disruption of the attachment relationship, which is really the blueprint for life, how we live our lives, these basic concepts of trust, care, love, honesty, dropping litter, what is a mother, what is a father, am I worthy, am I useless? All of these things you learn when you're very, very young indeed, according to the quality of that attachment relationship. And this underpins your psychological development for life and hugely affects your likelihood of long-term mental health problems. So a little bit of a physiology lesson here. The red area there is the amygdala, a very primitive part of the human brain. It fires in response to fear in the environment. The green area is the far more sophisticated human part of the brain. Animals don't have that green area. And these two areas are in constant debate with one another. If a frightening experience happens in the environment, your amygdala, the area in red, will fire and tell you to get out. Fight, flight, freeze is the hormonal response it triggers. But a fraction of a second later, the prefrontal cortex will kick in and actually debate with the amygdala as to how you respond. And the qualities and connectivity and networks of these two areas are very much determined by your early trauma history. So this is the normal developmental picture. But if you subject a child to trauma, if that child is growing up, especially in the pre-verbal years, always scared, always frightened, then you develop this hyper amygdala reaction, which then later translates into adult mental health problems and especially addictions. So it's very hard to treat. So when you've had this experience of this insecure attachment, you create this personal identity. I'm bad, I'm unlovable, I can't achieve. And also that the world is bad, the world is dangerous, people are out to hurt me. And this is such an overwhelming negative experience that what so many people choose to do under this circumstance is simply numb themselves with sedating substances, particularly substances such as opiates and particularly alcohol, which is a far more dangerous and prevalent substance than opiate misuse. So you get this very rigid picture that results as a result of that early childhood trauma. Now, the clinical and social and healthcare and financial burden of alcohol addiction is huge. 6% of people have what we would call a full alcohol dependency. This is like physical dependence on alcohol, having to drink in order to prevent physical withdrawal symptoms, but a much higher figure, up to 30, maybe even 40% in these post-COVID times, drink harmfully. So that is drinking over 14 units a week, and you're drinking having effect on your psychosocial functioning. So a massive number of people, a massive financial burden, a massive market of people who are not well treated by traditional treatments. So at best, current best treatments for alcoholism have a 75 to 80% treatment resistance. That is the very best modern medicine can throw at you, that rehabs don't work, relapse is high, and alcoholism continues. And of course, the financial costs are staggering. £3.5 billion a year in the NHS is spent on this. And there are no single treatments. There's no single drug on the market to date that treats alcoholism. So we have what we call polypharmacy, where we treat multiple symptoms, low mood, mood swings, poor sleep, anti-craving drugs. We have polypsychotherapies. We have sophisticated rehab units. we have AA, we have MAC groups, individual therapy, group therapy. All of these are partially successful for some patients some of the time, but the rates of relapse are huge. And of course, many other associated issues like self-harm and suicide. So the take-home message here is that A, alcoholism is huge, B, it's extremely expensive to treat, but C, and this is crucial, the current best treatments of modern medicine are just not working for these people. So psychedelics have quite a rich history in treating alcoholism. Indeed, the majority of the work done with LSD psychotherapy in the late 50s and early 60s was for alcoholism. And Krebs and Johansson did an important study in which they did a meta-analysis of that work and found a very strong effect size, which really does say that we really need to revisit the role of psychedelics in treating addictions and particularly alcoholism. This has been done in modern times by Michael Bogenschutz, who used psilocybin therapy for alcohol addiction, and found that the greater the psycho-spiritual mystical effect, the more people stayed sober with a reduction in craving. So there's a rich history of using classic psychedelics for alcohol addiction. But I'm going to turn my attention to this wonderful molecule, 3,4-methylenedioxymethamphetamine. Now, we know that classic psychedelics have a rich history in treating alcoholism, but would MDMA work? That's the question we asked ourselves when we started our study. It doesn't typically cause a psychospiritual experience like LSD or psilocybin, but we do know that MDMA has profound effects on treating trauma. And we do know that trauma is very heavily represented in people with alcoholism. So we put the two and two together and we came up with the world's first study to address alcoholism using MDMA-assisted psychotherapy. Now, I would say that MDMA is the perfect tool for treating people with trauma. It's short-acting, about 4 to 5 hours. We have a mild perceptual disturbance with MDMA, but not like the classic psychedelics with what we might call ego dissolution. It's a very pleasurable drug to take. Now, this makes it clinically deliverable, which is very important. There is a far greater pool of patients who would tolerate the use of MDMA over psilocybin. So as a psychotherapist and psychiatrist, it's very much my preferred compound for assisting psychotherapy. It's incredibly safe. And it's this ability to enhance empathy through safe access to painful traumatic memories that makes it such a good tool. Now, it works across a number of different receptors. Often people think MDMA just increases serotonin. It's a bit more sophisticated than that. It increases what we call 5-HT1A and 1B receptor activity, which results in this positive mood. There's a mild effect in the 2A receptors, which increases creative thinking. We also have this very paradoxical effect with both stimulation and relaxation at the same time, which puts the patient into what we call the optimal arousal zone for psychotherapy. And then it has this effect on empathy and bonding. And it does this partly through the release of a hormone called oxytocin. Now, oxytocin, as you know, is the hormone released from the brains of breastfeeding mothers. And this engenders a sense of empathy and bonding. So when you add up all of these effects together, you get this wonderful sentence: MDMA selectively inhibits the fear response whilst leaving the other faculties intact. That's very, very important when it comes to designing clinical programs that can treat patients. So the fear part of the brain, the amygdala, is switched off, but they can still do other aspects of psychological functioning in ways that are far above the classic psychedelics like psilocybin or LSD. They can remember, they can debate, they can recall past memories, they can have conversations with their psychotherapist in the MDMA state. So it does, in my opinion, make MDMA a far more tolerable and preferable drug for combining with psychotherapy to treat addictions. And here's our traumatized brain. This is our patient who unfortunately had child abuse and maltreatment, and they grew up with this excessive amygdala response and this shrunken prefrontal response. They're overly scared of everything. They're unable to see the good in anything. They have a head full of negative narratives about their self and the world. And what happens when you give them MDMA? You get the complete opposite. You get a shrinking of the amygdala, a turning off of that fear response, and a boosting of the prefrontal cortex response, which puts the patient into an ideal position to carry out trauma-focused psychotherapy. So we put together our study, the world's first MDMA study to look at addictions. It was an open label safety and tolerability study. So what that means is no control group, no placebo, which you may say sounds a bit methodologically unsound, Dr. Sessa, but actually it's a requirement. When you're using a new drug in a new condition for the first time, you have to start with this open label safety and tolerability study. It was an 8-week course of psychotherapy, and we saw 14 patients, and they received 2 MDMA sessions over the course of the 8 weeks. So what we did is we took people in who were heavy daily dependent drinkers. They underwent a detox to bring them down to 0 in terms of alcohol intake. They then came into the 8-week course, which, like most psychedelic protocols, is a mixture of drug and non-drug sessions. They get 2 sessions with MDMA interspersed with non-drug preparation, followed by integration sessions. And then we followed up the cohort at 3, 6, and 9 months. Now, this is a spectacularly boring table, and I like it because it's spectacularly boring, because this is the demonstration that across the board, we saw no serious adverse events, no abnormal blood changes, no abnormal ECGs, no suicides. Everybody positively gave positive qualitative reports. It was very well tolerated. So a spectacularly boring result, but exactly what you want in a safety and tolerability study. And indeed, the safety profile of MDMA is extremely high. We have very low rates of morbidity and mortality. It is just not on the radar for drug services. Despite the sort of popular media representation of clinical of MDMA, of recreational ecstasy being dangerous. Actually, if you think about it, 750,000 doses of ecstasy are taken in the UK every weekend. 750,000 doses every weekend for the last 30 years. Yet the rates of morbidity and mortality are staggeringly low. And that's recreational ecstasy. Once you start talking about clinical MDMA, using screened patients in a controlled clinical setting, you reduce those risks right down to close to 0, with very few adverse effects and a very well-tolerated treatment by patients. So we must not make inferences about clinical MDMA based on ravers and recreational ecstasy. This is a medical drug in a medical setting. So we looked at some of these physiological aspects of the MDMA experience just to demonstrate to the ethics committee and others who were perhaps cynical or cautious. And as you can see, you get a mild rise in blood pressure and temperature, and you get positive drug effects over the course of the 8-hour day. And all the results come back down to 0 where they started, demonstrating no abnormal physiology associated with the MDMA experience in a clinical setting. People often ask me this, but what about come downs? What about Blue Monday, or what people call Black Tuesday or Suicide Wednesday? This anecdotal report from the recreational ecstasy community of come downs and low mood and affect after taking MDMA or ecstasy. Well, we looked at this in our clinical sessions. So on this profile of mood states, a score of 0 means normal mood or flat mood. Positive numbers mean depression, and negative numbers mean quite the opposite of depression, an elevated or positively felt mood. And we telephoned all of our participants daily for a week after their MDMA sessions. And here are the outcomes. An afterglow that lasts a week. We just didn't see come downs or low mood. So looking at the outcomes, now this is the study we conducted before the MDMA study, the treatment as usual study as a comparison group. As you can see, everyone heavily drinking before their detox. They all come down to 0 at the point of detox. And very sadly, but not unexpectedly, over the course of the next 9 months, they've pretty much returned to the same levels of drinking. And this is with the very best that modern medicine can throw at the alcoholic. This is MAP groups, anti-craving drugs, rehab, psychotherapy, AA, etc., etc. This is the best that we can do in modern medicine. Now, that's the outcomes that we had with the MDMA group at the end of the 9 months. Came in with high levels of drinking, down to 0 at detox, and only that small percentage who had returned to the pre-levels of drinking. And I've put these two graphs on top of one another here and changed the units to those consuming over 14 units a week, which demonstrates that one of the definitions of alcoholism. And as you can see, in the treatment as usual study, 75% were back to pre-levels of drinking, compared to 21%. Now, I want this graph for those of you in the audience, to be the take-home message. You do not see graphs like this in human psychopharmacology research. An 8-week course of MDMA therapy radically alters the treatment outcomes compared to the best that modern medicine can offer alcoholics. I want this etched on your mind. Now, the next step, obviously, is to carry out a randomized control study to test the efficacy of MDMA against placebo. And this is what we're now doing at Awakn Life Sciences, with an eventual goal of seeing MDMA-assisted psychotherapy approved by the FDA and EMA for the treatment of alcohol use disorder in the future. And this is well underway. This is an interesting thing. Why are psychedelics so difficult to deliver? Well, these are some of the things that I hear back from me. Well, you're swapping one dangerous drug for another. Well, that's absurd. There is nothing more dangerous than drinking a bottle of vodka a day. The idea that a couple of sessions with MDMA is somehow harmful, if it gets you off the drinking, it's absolutely validated. The next one, is there a risk of addictions to psychedelics? Absolutely not. Very low. We don't see this in animal studies. We don't see it in epidemiology either. You don't get people breaking into your house to steal your telly to get their next fix of ecstasy or magic mushrooms. It just doesn't happen. These drugs are not on the radar with drug services. Lack of research of proven efficacy, that's also completely wrong. All of the psychedelic studies of the last 10 to 15 years have been extremely positive. Sends the wrong message regarding drug policy. Don't even get me started on talking about drug policy, which is unethical, unpoliceable, unwinnable and dangerous, and causes deaths, harms and addictions. There's very strong evidence for that. Costly and difficult, absolutely. Psychedelic research is costly and difficult, and it has a very strong, erroneous, stigmatizing public perception against the risk of psychedelics. So we have a lot of work to be doing in reversing that. Now, I'm very privileged to have been working in psychedelic research for over almost 20 years now, worked on studies with MDMA and LSD and psilocybin and DMT and ketamine, and great to see all of these teams here in the UK, world leaders of that. And talking of world leaders brings me on to some final comments about the Awakn Life Services, the Life Sciences. We have opened a clinic in Bristol, and we are opening 15 to 20 clinics across the UK and Europe in the next few years. We have a staggeringly good scientific advisory team, world leaders, with the Mitt Hoffers and Celia Morgan and Matt Johnson from Johns Hopkins University, led by Professor David Nutt. We're carrying out psychedelic clinics, initially with ketamine and later with MDMA and psilocybin. We're carrying out novel research with new molecules, and we're carrying out research, as I mentioned, furthering our current study with alcoholism with MDMA. So we really are at the front of the pack on this. There is no better scientific committee in the world at this. Nobody else who has been working so long as our team. We have these new novel MDMA-like compounds that we're developing to further enhance the use of MDMA to assist psychotherapy. And we are now publicly trading on the Neo Stock Exchange. It's a fantastic team. Do come and visit us in Bristol and look at all of the groundbreaking work that we're doing with MDMA and ketamine out of our clinics. And I thank you very much for your time and for listening. This is an exciting time in the field of psychedelic research. It's a great privilege to have been here for so long, and a massive validation of my own personal work to see this moving away from research and academia into proper treatments and delivery of these treatments for the massive burden of people who are failing to be met by current traditional psychiatry. So thank you very much for your time.